What is the rationale behind using HbAC as a diagnostic tool for diabetes, and what are the limitations of HbAC testing in diagnosing certain populations? Answer: hemoglobin as HbAC reflects the average blood glucose level over the past 2 to 3 months, making it a reliable tool for assessing long-term glucose control. It is widely used to diagnose diabetes and monitor treatment effectiveness. Rationale: HbAC provides a snapshot of blood glucose over a prolonged period, reducing the variability that may be seen in single-point tests such as fasting plasma glucose (FPG) or the oral glucose tolerance test (OG). The American Diabetes Association (ADA) and the World Health Organization, who have set the diagnostic threshold for diabetes at NISHIT equals 6.5%. Limitations: anemia and hemoglobin variants. Conditions such as sickle cell anemia, hemoglobin C, and other hemoglobinopathies may affect HbAC accuracy, leading to either falsely high or low readings. Kidney disease. Chronic kidney disease (CKD) can affect red blood cell turnover, which may alter HbAC levels independently of blood glucose. Pregnancy. Pregnancy-related changes in red blood cells can cause inaccuracies in HbAC results, necessitating alternative testing methods like OGTT. Guidelines. The ADA recommends using FPG or OGTT in cases where HbAC is unreliable due to conditions like anemia or pregnancy. Clinical judgment should be exercised, and multiple diagnostic criteria including HbAC, FPG, and OGT may be necessary for an accurate diagnosis. What factors should be considered when setting individualized glycemic targets for a patient with type 2 diabetes, and how do these targets differ across various guidelines? ADA versus OS. Answer: individualized glycemic targets take into account a patient's age, comorbidities, and life expectancy, among other factors. The goal is to balance achieving optimal glucose control while minimizing the risk of hypoglycemia and maintaining quality of life. Factors to consider: age and life expectancy. Older patients or those with limited life expectancy may have less stringent targets, e.g., HbAC 8% instead of 7%. Comorbid conditions. Patients with cardiovascular disease or kidney disease may require more stringent control, while those with frailty may have more relaxed targets. Hypoglycemia risk. A history of frequent hypoglycemia might prompt a more lenient approach to control, as avoiding hypoglycemia becomes a priority. ADA versus AAC. Guidelines. ADA, American Diabetes Association, recommends a target HbAC of 7% for most non-pregnant adults, but acknowledges that individualized targets may be appropriate for some patients. AAC, American Association of Clinical Endocrinologists, supports a more aggressive target with an HbAC goal of 6.5% for many adults, especially those with a longer life expectancy and no history of hypoglycemia. Guidelines. ADA, a more flexible approach allowing for targets between 6.5% and 8% based on individual patient circumstances. OS generally advocates for lower targets, but with a strong focus on the avoidance of hypoglycemia and other adverse effects. 58-year-old male with type 2 diabetes presents with a recent diagnosis of chronic kidney disease, stage 3. His current HbAC is 7.2% and he is taking metformin and a sulfonylurea. Based on current guidelines, what changes, if any, would you recommend in his pharmacological treatment? Answer: in this scenario, the patient's recent diagnosis of chronic kidney disease (CKD) requires careful consideration of his current medication regimen. Key considerations: metformin. The use of metformin in patients with CKD is generally contraindicated when the estimated glomerular filtration rate (EGFR) is below 30 ml/min on 0.73 mm due to the risk of lactic acidosis. However, metformin can be continued in patients with an EGFR 30 ml/min on 0.73 mm, but it may require dose adjustment. At stage 3 CKD, EGFR 3059 mmol on 0.73 m, metformin should be used cautiously and at a reduced dose. Sulfonylureas. The risk of hypoglycemia is higher in CKD patients due to impaired renal clearance of sulfonylureas. A safer alternative may be a long-acting GLP-1 receptor agonist, such as liraglutide or semaglutide, which have renal protective benefits and a low risk of hypoglycemia. Recommendations: discontinue or reduce the dose of metformin if the EGFR is near or below 45 ml/min on 0.73 m. Consider switching from sulfonylurea to a E1 receptor agonist, as these agents are effective in lowering blood glucose, provide weight loss benefits, and have demonstrated renal protection. Monitor kidney function closely and adjust medications accordingly. Guidelines. The ADA provides specific recommendations on adjusting metformin and sulfonylureas in the presence of CKD, KDIGO, kidney disease. Improving global outcomes also recommends a careful approach to medication in patients with CKD with a focus on drugs with renal benefits. Explain the concept of total daily insulin EDI and how it relates to basal bolus therapy in managing type 1 diabetes. Answer: total daily insulin EDI is the total amount of insulin a patient requires to maintain blood glucose control over 24 hours, including both basal and bolus insulin. Basal bolus insulin regimen. Basal insulin background insulin covers the body's insulin needs during fasting periods, and its dosage remains relatively consistent throughout the day. It is typically given as a long-acting insulin, e.g. glargine ditemir. Bolus insulin, prandial insulin, is taken before meals to cover the rise in blood glucose that occurs after eating. It is usually rapid-acting insulin, e.g. Lispro-Aspar. TDI calculation. TDI can be estimated based on a patient's body weight and insulin sensitivity. A common guideline is that the total daily dose is around 0.5 1.0 units a day. Formula for estimating insulin doses. Basal insulin, typically 50% of TDI. Bolus insulin, the remaining 50% is divided among 3 meals based on carbohydrate intake. Example, for a 70 kilograms patient with a TDI of 0.8 units GAY, the total dose would be 56 units, 70 kilograms x 0.8 units. Basal dose, 28 units, 50% of TDI. Bolus dose, 28 units, divided among 3 meals. Guidelines. The ADA recommends regular adjustments to insulin therapy based on blood glucose monitoring and HbAC levels, with the goal of achieving optimal control without excessive hypoglycemia. Mr. Thompson, a 72-year-old man with a history of type 2 diabetes, hypertension, and hyperlipidemia, has been struggling with frequent hypoglycemic episodes despite his insulin therapy regimen. He is currently on a basal bolus insulin regimen, long-acting insulin 30 units in the morning, rapid-acting insulin 8 units with meals, along with metformin. What steps should Mr. Thompson's diabetes care team take to address his hypoglycemia? Answer: in this scenario, Mr. Thompson's diabetes care team needs to carefully evaluate his insulin regimen, comorbidities, and the risk factors for hypoglycemia. Key steps: review insulin dosage. Mr. Thompson's insulin regimen may need adjustment. The basal insulin dose of 30 units could be too high for a patient of his age, especially given the increased risk of hypoglycemia in the elderly. A bolus insulin, 8 units per meal, might also need to be recalibrated based on his carbohydrate intake and blood glucose response. Evaluate meal timing and carbohydrate intake. If Mr. Thompson is not consistently eating meals or if his carbohydrate intake varies, this can lead to hypoglycemia. It is essential to ensure that his meals are well balanced and that the insulin dose corresponds to his carbohydrate consumption. Consider the un receptor agonist. Since Mr. Thompson is already on metformin, adding a the receptor agonist such as liraglutide may help with weight management and improve glycemic control, reducing the need for large doses of insulin. Continuous glucose monitoring (CGM). Implementing CGM could help track blood glucose trends and detect hypoglycemic episodes in real time, allowing for quicker adjustments to his insulin regimen. Guidelines. ADA emphasizes the importance of minimizing hypoglycemia while achieving glycemic control, particularly in older adults. The Endocrine Society and AAC recommend using lower insulin doses or considering non-insulin therapies for patients with a high risk of hypoglycemia. HDSLT inhibitors impact glucose control in patients with type 2 diabetes, and what are the primary safety concerns associated with their use? Answer: Odium glucose-Cotran Sporter 2 EDLT inhibitors are a class of medications used in the management of type 2 diabetes. They work by blocking the EDLT protein in the kidneys, which is responsible for reabsorbing glucose from urine back into the bloodstream. Mechanism of action: glucose excretion. By inhibiting EDLT, these drugs increase glucose excretion in the urine, thus lowering blood glucose levels. Additional benefits: EDLT inhibitors are associated with weight loss, modest blood pressure reduction, and renal protection, especially in patients with early-stage chronic kidney disease (CKD). Safety concerns: genital mycotic infections. The increased glucose in urine can promote the growth of fungi, leading to higher rates of genital yeast infections. Dehydration and hypotension. SLT inhibitors can lead to dehydration due to increased urination, which may cause hypotension, particularly in elderly patients or those with renal impairment. Ketoacidosis. Though rare, diabetic ketoacidosis (DKA) has been reported even in patients with normal blood glucose levels. Renal impairment. The drugs are contraindicated in patients with severe renal impairment, EGFR 30 ml manum 0.73 mm, as their effectiveness diminishes at low levels of kidney function. Guidelines. The ADA and AAC recommend consider ADLT inhibitors as part of the therapeutic regimen for patients with type 2 diabetes and cardiovascular or renal disease. Explain the role of GLP-1 receptor agonists in managing type 2 diabetes and discuss their effects on weight and cardiovascular outcomes. Answer. Glucagon-like peptide on GLP-1 receptor agonists are a class of injectable medications that mimic the action of the endogenous GLP-1 hormone, which plays a critical role in glucose regulation. Mechanism of action. Glucose-dependent insulin secretion GLP-1 agonists stimulate insulin release from the pancreas in response to meals, thereby lowering postprandial blood glucose inhibition of glucagon secretion. They suppress glucagon release, reducing hepatic glucose production, slowing gastric emptying. GLP-1 agonists slow gastric emptying, which helps with satiety and reduces post-meal blood glucose spikes. Effects on weight and cardiovascular outcomes. Weight loss. GLP-1 agonists promote weight loss by increasing satiety, which is beneficial for many patients with type 2 diabetes who are overweight or obese. Cardiovascular benefits. Clinical trials, e.g. LEAD, SUSTAIN, have shown that GLP-1 agonists, such as liraglutide and semaglutide, reduce the risk of major adverse cardiovascular events, including heart attack, stroke, and cardiovascular death. Guidelines. The ADA recommend GLP-1 receptor agonists as a preferred treatment option for patients with type 2 diabetes and a history of cardiovascular disease or at high risk for cardiovascular events. What are the most common side effects of metformin, and how should these be managed in clinical practice? Answer. Metformin is a first-line treatment for type 2 diabetes and works by improving insulin sensitivity and reducing hepatic glucose production. Common side effects. Gastrointestinal issues. Nausea, diarrhea, and abdominal discomfort are common, particularly when starting therapy or increasing the dose. Lactic acidosis. Though rare, lactic acidosis is a potentially serious side effect, particularly in patients with renal impairment or other contraindications. Management. Start with a low dose. To minimize gastrointestinal side effects, metformin should be initiated at a low dose, e.g. 500 mg daily, and titrated up gradually. Take with meals. To reduce gastrointestinal discomfort, metformin should be taken with meals. Monitor renal function. Regular monitoring of renal function is critical, particularly in older patients or those with CKD, to ensure safe use of metformin. What is the role of continuous glucose monitoring (CGM) in managing diabetes, and how does it improve patient outcomes? Answer. Continuous glucose monitoring (CGM) provides real-time data on glucose levels throughout the day and night, allowing for better management of diabetes. Role and benefits. Real-time glucose data. CGM systems measure glucose levels in interstitial fluid every few minutes, offering continuous insights into glucose trends, hypoglycemia, and hypoglycemia prevention. CGMs can alert patients to impending hypoglycemia or hypoglycemia, allowing for timely interventions. Improved glycemic control. Studies have shown that CGM usage, especially in patients with type 1 diabetes, leads to improved glycemic control, reduced HbAC, and a lower risk of hypoglycemia. Guidelines. The ADA recommends CGM for patients who require intensive insulin therapy, especially those with frequent hypoglycemia or poor glycemic control, despite multiple daily injections. Explain the importance of individualized treatment plans in diabetes management and how pharmacological therapies should be adjusted based on patient characteristics. Answer. Individualized treatment is crucial for managing diabetes because each patient has unique needs and challenges related to their condition. Key factors for individualization: age and comorbidities. Older adults or those with comorbid conditions, e.g. cardiovascular disease (CKD), may require more cautious approaches to insulin dosing or may benefit from specific drugs, ADLT inhibitors or GLP-1 receptor agonists. Risk of hypoglycemia. Patients with a higher risk of hypoglycemia may need less aggressive glucose-lowering strategies, such as lower insulin doses or alternative medications like DPP-4 inhibitors or GLP-1 agonists. Lifestyle and preferences. Patient preferences regarding injectable medications, convenience, and weight loss benefits should be considered when choosing therapies. Guidelines. The ADA emphasizes that the choice of pharmacological agents should be based on a comprehensive assessment of the patient's medical history, comorbidities, and treatment goals. How can healthcare professionals identify and address diabetes-related emotional distress in patients, and what evidence-based strategies are most effective for mitigating its impact on self-management? Answer: diabetes-related emotional distress (DED) can significantly impact self-management, leading to poor glycemic control and treatment adherence. Healthcare professionals can identify D through the Diabetes Distress Scale (DDS) or patient interviews, looking for signs such as anxiety, frustration, and feelings of being overwhelmed. Effective strategies include smart goal setting. Use specific, measurable, achievable, relevant, and time-bound goals to reduce overwhelm and enhance motivation. Cognitive behavioral therapy (CBT). This approach helps patients challenge negative thought patterns, fostering healthier coping mechanisms and problem-solving skills. Peer support. Encouraging involvement in diabetes support groups can reduce stigma, improve self-management, and provide emotional validation, education, and reassurance. Reaffirm that managing diabetes is a gradual process and encourage self-compassion. Research has shown that addressing D improves clinical outcomes. For instance, individuals with reduced distress tend to have better HbAC levels and fewer diabetes-related complications. Discuss the concept of time in range (TER) in continuous glucose monitoring (CGM) and its clinical significance. How does it compare with HbAC as a metric of glycemic control? Answer: time in range (TER) refers to the percentage of time a patient's glucose levels remain within a target range, typically 7018 or EDDLs, measured by continuous glucose monitoring (CGM). TIR is considered a more sensitive indicator of glycemic control compared to HbAC, as it provides real-time data on fluctuations, offering a clear picture of daily glucose variability. Clinical significance. High TIR is associated with a reduced risk of complications such as retinopathy, nephropathy, and cardiovascular disease. For example, maintaining a TIR of over 70% is linked to a 2–3% reduction in the risk of diabetes complications. In contrast, HbAC, a long-term average of blood glucose levels, can miss important fluctuations, including hypoglycemia or postprandial spikes, and doesn't capture glucose variability. This makes TIR particularly useful for monitoring at-risk patients or those on insulin pumps. The American Diabetes Association (ADA) and European Association for the Study of Diabetes (EAST) recommend TIR as a critical marker, emphasizing the importance of individualizing targets based on risk factors. Maria, a 45-year-old with type 2 diabetes, has been using an insulin pump for 3 months. She reports frequent postprandial hypoglycemia despite adhering to bolus recommendations. Maria's CGM data show prolonged elevations in glucose levels 2 hours after meals. What adjustments should be made to Maria's pump settings, and what additional education should be provided to address her hypoglycemia? Answer: Maria's persistent postprandial hypoglycemia suggests a mismatch between her insulin delivery and her food intake. To optimize her insulin pump settings, the following adjustments should be considered. Evaluate insulin to carbohydrate ratio (ACA). Ensure her ICR is appropriate by calculating her insulin needs based on carbohydrate content, adjusting for her specific insulin sensitivity. Pre-bolus timing. Teach Maria to administer insulin 1–5–3 minutes before meals to ensure insulin peaks when blood glucose rises. Basal rate review. Examine overnight and fasting glucose levels to confirm basal insulin settings are effective in maintaining glucose control during non-meal times. Advanced bolus features. If she has meals high in fat or protein, the use of an extended bolus or a dual-wave bolus may help. Education on proper carbohydrate counting is crucial. Reinforce accurate portion sizes and encourage the use of tools like food tracking apps. Teaching Maria how to adjust her insulin based on exercise, stress, and illness can further improve her glucose control. Describe how cognitive behavioral therapy (CBT) can help address diabetes-related unhealthy habits and promote lasting behavior change. Answer: cognitive behavioral therapy (CBT) addresses the psychological aspects of diabetes care by focusing on changing maladaptive thought patterns that contribute to unhealthy behaviors. This approach is effective for managing diabetes-related distress, promoting adherence to treatment plans, and improving self-management. Key elements of CBT in diabetes care: cognitive restructuring. Identify and challenge irrational thoughts, such as "I can't control my diabetes," replacing them with empowering beliefs. Behavioral activation. Encourage healthy habits like regular exercise and meal planning, reinforcing these actions with positive reinforcement. Goal setting. Break down long-term health goals into manageable, realistic steps. These goals should be specific, measurable, and achievable, which increases the likelihood of success. Stress management techniques address emotional triggers that contribute to unhealthy eating or medication non-adherence. Studies show that CBT can reduce HBAC by 0.8% and improve psychological well-being by alleviating anxiety and depression related to diabetes management. What are the limitations of hybrid closed-loop systems, and how can patients optimize their use for better glycemic outcomes? Answer: hybrid closed-loop systems like the Medtronic 670 grams combine insulin pumps with CGMs to automate basal insulin delivery. While effective, they have limitations, including calibration requirements. Frequent calibrations with blood glucose measurements are often needed to ensure sensor accuracy. Sensor lag: the interstitial fluid used by CGMs may lag behind blood glucose readings, leading to delayed insulin adjustments. Manual bolus input: for meals and corrections, patients must still calculate and deliver boluses as the system does not fully automate meal insulin delivery. Inaccuracies in extreme conditions: the system may struggle with hypoglycemia or hyperglycemia, leading to errors in insulin delivery. Optimization strategies: regular sensor replacements and calibration to ensure accurate readings. Manual override during periods of illness or exercise when basal insulin needs may change rapidly. Carbohydrate counting education to improve bolus accuracy. Explain the role of motivational interviewing in fostering adherence to diabetes self-management plans. Include key principles and techniques. Answer: motivational interviewing is a patient-centered communication approach designed to enhance motivation for behavior change, particularly in managing chronic conditions like diabetes. It empowers patients to take ownership of their health decisions while respecting their autonomy. Key principles of express empathy, build rapport by listening actively and validating the patient's feelings. Develop discrepancy, help the patient recognize the difference between their current behaviors and their long-term goals. Support self-efficacy, strengthen the patient's belief in their ability to change by highlighting past successes. Roll with resistance. Rather than arguing, explore ambivalence and offer options. Techniques: open-ended questions encourage patients to discuss their motivations and concerns. Reflective listening: reiterate patient statements to demonstrate understanding. Affirmations: acknowledge patient strengths and progress. Research demonstrates that MI improves self-management behaviors, reduces HBAC, and enhances patient satisfaction by addressing ambivalence and fostering a collaborative relationship between patient and healthcare provider. What are the benefits and challenges associated with the use of artificial pancreas systems, and how do they contribute to improving diabetes management? Answer: artificial pancreas systems apps combine insulin pumps with CGMs to automate insulin delivery in response to glucose readings. They aim to mimic the pancreas' natural function, providing improved glucose control and reduced burden for patients. Benefits: improved glucose control. APS can maintain near normal glucose levels with less effort, leading to better HBAC without increased hypoglycemia. Reduced glycemic variability. By adjusting insulin delivery based on real-time data, APS helps minimize fluctuations in blood glucose. Ease of use: automating basal insulin delivery reduces the number of decisions patients need to make daily. Challenges: system accuracy. The APS relies on CGM data, which can sometimes be inaccurate, leading to over or undercorrection of glucose levels. Cost: the devices and continuous monitoring required can be expensive and may not be covered by all insurance plans. User adherence: patients still need to monitor their device and manage meals, which can be cumbersome. Despite these challenges, studies show that APS leads to improved patient outcomes with increased TIR and fewer complications. How does chronic hypoglycemia contribute to the development of diabetes-related complications, and what preventive strategies can healthcare professionals employ to minimize risk? Answer: chronic hypoglycemia damages blood vessels, nerves, and organs over time, leading to diabetes-related complications such as retinopathy, nephropathy, neuropathy, and cardiovascular disease. The mechanisms include oxidative stress, inflammation, and glycation of proteins, which impair normal cellular function and tissue repair. Preventive strategies include tight glycemic control. Maintain HBAC levels below 7% to reduce the risk of complications using lifestyle changes, medications, and insulin therapy. Regular screening. Monitor for early signs of complications through routine checks like eye exams, kidney function tests, and foot exams. Blood pressure and lipid management. Control hypertension and hyperlipidemia to protect cardiovascular health. Patient education. teach patients about the importance of diet, exercise, and medication adherence. Healthcare professionals should tailor these strategies to individual patient needs, aiming for personalized care plans that optimize glycemic control and prevent complications. What unique challenges exist in managing diabetes in elderly patients, and how can care strategies be adapted to this population? Answer: managing diabetes in elderly patients presents unique challenges due to age-related factors like decreased renal function, cognitive decline, and the presence of multiple comorbidities. Additionally, polypharmacy and altered metabolism complicate treatment plans. Adapted care strategies include simplifying treatment regimens, minimize the number of medications to reduce the risk of side effects and improve adherence, individualized glycemic targets, set less stringent HbAC goals, e.g. 7.5, 8.0%, to avoid hypoglycemia, especially in frail patients, regular screening, monitor for complications more frequently, including kidney function and cognitive assessment, enhanced support systems involve family members, caregivers, or home health services to assist with medication management, meal planning, and physical activity. Overall, a holistic approach that balances glycemic control with quality of life is essential for elderly patients. Collaboration between multidisciplinary teams ensures comprehensive care and improved outcomes. What are the key challenges in managing type 1 diabetes in children, and how can healthcare professionals support both the child and their family in managing the condition? Answer: managing type 1 diabetes (TD) in children involves addressing both the child's medical needs and the psychosocial challenges faced by the family. Key challenges include adjusting insulin therapy. Growing children have fluctuating insulin needs due to changes in metabolism, activity, and diet. Psychosocial impact: diabetes can be emotionally taxing for both children and their families. Fear of hypoglycemia, body image concerns, and social stigma may lead to diabetes distress. Parental involvement: parents must monitor blood glucose, administer insulin, and coordinate care, often leading to stress and burnout. Support strategies: education. Provide diabetes education tailored to the child's developmental stage and ensure that caregivers understand the importance of consistent monitoring. Empowerment: encourage the child to take an active role in their care, gradually increasing independence as they age. Psychosocial support: offer counseling and connect families with diabetes support groups to reduce emotional strain. Type 2 diabetes involves insulin resistance and progressive beta cell dysfunction. Explain how these two factors interplay to contribute to hypoglycemia. Answer: in type 2 diabetes, insulin resistance occurs when peripheral tissues such as skeletal muscle, liver, and adipose tissue become less responsive to insulin. This leads to impaired glucose uptake, resulting in higher blood glucose levels. To compensate, the pancreas increases insulin secretion. However, over time, prolonged high glucose levels and fatty acids cause damage to pancreatic beta cells, impairing their function and reducing insulin secretion. This combination of insulin resistance and beta cell dysfunction leads to hypoglycemia in multiple ways. Insulin resistance prevents efficient glucose uptake, while reduced insulin production fails to suppress hepatic glucose production, causing elevated fasting glucose levels. As the disease progresses, patients may experience worsened insulin resistance, requiring even higher insulin levels to control blood sugar, leading to a vicious cycle. The American Diabetes Association (ADA) recommends managing these factors through lifestyle changes, medications like metformin, and monitoring blood glucose levels. Management focuses on improving insulin sensitivity, controlling blood sugar, and preserving beta cell function. Discuss the physiological changes during pregnancy that increase the risk of gestational diabetes. What are the postpartum risks for both the mother and the child? Answer: during pregnancy, hormonal changes, particularly the secretion of human placental lactogen, estrogen, and progesterone, increase insulin resistance to ensure adequate glucose supply for fetal growth. In most women, the pancreas compensates by increasing insulin production. However, in some women, the pancreas fails to keep up with the increased demand, resulting in gestational diabetes (GDM). Postpartum women with GDM are at a significantly higher risk for developing type 2 diabetes later in life. Studies indicate that up to 50% of women with GDM develop type 2 diabetes within 10 years. For the child, risks include being born with macrosomia, large birth weight, which increases the risk of delivery complications, neonatal hypoglycemia, and a higher likelihood of developing obesity and type 2 diabetes later in life. The ADA and American College of Obstetricians and Gynecologists (ACOG) recommend postpartum screening for women with GDM at 6-12 weeks and ongoing monitoring every 1-3 years. Lifestyle modifications, including diet and exercise, are vital for preventing future diabetes. Mr. Thompson, a 45-year-old with type 1 diabetes, reports frequent hypoglycemic episodes at night and inconsistencies in his glucose readings using fingerstick tests. He is considering continuous glucose monitoring (CGM). What factors should he consider, and how might CGM help him manage his diabetes more effectively? Answer: Mr. Thompson should consider several factors before adopting CGM. First, CGM provides continuous, real-time glucose data, helping identify trends and fluctuations, especially useful for nocturnal hypoglycemia, which may go undetected with traditional testing. CGM systems also offer alerts for high or low blood glucose, enabling timely corrective action. However, the initial cost of CGM devices, insurance coverage, and the learning curve required for proper use are significant factors. Additionally, while CGM improves glucose control and reduces hypoglycemia risk, it is not a substitute for frequent blood glucose monitoring when necessary. For Mr. Thompson, CGM could help him better understand his glucose patterns and adjust his insulin regimen accordingly. The ADA recommends CGM for patients with type 1 diabetes who experience frequent hypoglycemia or have difficulty achieving glycemic control. Integrated systems allow for automated insulin delivery, providing more precise and responsive management. Regular follow-up with his healthcare team is crucial to ensure effective use of the technology. Describe the role of GLP-1, glucagon-like peptide bond, in glucose homeostasis and its therapeutic implications in diabetes management. Answer: GLP-1 is an incretin hormone released by the L cells of the small intestine in response to food intake. It enhances insulin secretion in a glucose-dependent manner, meaning it only stimulates insulin release when blood glucose levels are elevated, preventing hypoglycemia. GLP-1 also inhibits glucagon release, reducing hepatic glucose production, slows gastric emptying, and promotes satiety, which helps control postprandial glucose levels. Therapeutically, GLP-1 receptor agonists G-liraglutide, semaglutide, are used to treat type 2 diabetes. These medications improve glycemic control and can also aid in weight loss, which is beneficial for many type 2 diabetes patients. Moreover, GLP-1 receptor agonists have cardiovascular benefits, such as reducing the risk of major adverse cardiovascular events. The ADA and European Association for the Study of Diabetes (EAST) recommend GLP-1 receptor agonists as part of individualized treatment plans for patients with type 2 diabetes, especially those with obesity or cardiovascular risk factors. Discuss the role of lifestyle modifications and pharmacological interventions in preventing type 2 diabetes in individuals with prediabetes. Answer: lifestyle modifications are the primary intervention for individuals with prediabetes, and they can significantly reduce the risk of developing type 2 diabetes. These changes include adopting a healthier diet, low in processed foods and high in fiber, increasing physical activity, aiming for at least 150 minutes of moderate intensity exercise per week, and achieving a weight loss of 5% of body weight. Studies such as the Diabetes Prevention Program (DPP) show that these measures reduce the risk of diabetes by over 50%. For high-risk individuals, pharmacological interventions like metformin may also be considered. Metformin improves insulin sensitivity and reduces hepatic glucose production. It is especially useful for individuals with a BMI 35 kilograms and a history of gestational diabetes or severe hypoglycemia. The ADA guidelines emphasize early intervention for individuals with prediabetes, focusing on lifestyle changes and regular monitoring of blood glucose levels. Combining lifestyle changes with pharmacological therapy offers the best chance of preventing type 2 diabetes and improving overall health outcomes. Explain how chronic hypoglycemia contributes to oxidative stress and its role in diabetic complications. Answer: chronic hypoglycemia contributes to oxidative stress through several mechanisms. Elevated blood glucose levels increase the flux through the polyol and hexosamine pathways, both of which generate reactive oxygen species, ROS. ROS are unstable molecules that cause cellular damage, including lipid peroxidation, protein denaturation, and DNA mutations. This oxidative damage accelerates endothelial dysfunction, leading to the development of microvascular complications like retinopathy, nephropathy, and neuropathy. In addition, our OS stimulate the formation of advanced glycation end products, AGEs, which further contribute to inflammation and tissue damage, especially in blood vessels. AGEs promote atherosclerosis and macrovascular complications, including coronary artery disease and stroke. To mitigate oxidative stress, the ADA recommends tight glycemic control, along with potential use of antioxidants, such as vitamin E, to prevent the damaging effects of our OS. The combination of good glucose management and antioxidant-rich diets can reduce complications and improve long-term outcomes. Discuss the benefits and challenges of using insulin pumps and closed-loop systems in diabetes management. Answer: insulin pumps provide continuous subcutaneous insulin delivery, offering more precise control over blood glucose levels compared to multiple daily injections. MDIS, they allow for basal background insulin delivery and bolus mealtime doses adjusted for individual needs. This improves flexibility in diabetes management, especially for patients with type 1 diabetes. Closed-loop systems, also known as artificial pancreas systems, combine an insulin pump with continuous glucose monitoring (CGM) to automatically adjust insulin delivery based on real-time blood glucose levels. These systems aim to maintain glucose levels within the target range, reducing the risk of both hypoglycemia and hyperglycemia. The benefits of insulin pumps and closed-loop systems include improved glycemic control, decreased risk of long-term complications, and increased quality of life. However, challenges include the initial cost, the need for patient education, and the risk of mechanical failures or sensor inaccuracies. Ongoing monitoring and adjustments are necessary for optimal performance. How do psychological factors such as stress and depression affect diabetes management and outcomes? Answer: the kidneys play an essential role in glucose homeostasis by filtering glucose from the blood through the glomeruli. In a healthy individual, most of the filtered glucose is reabsorbed in the proximal tubules. However, in the setting of chronic hypoglycemia, the renal threshold for glucose reabsorption is surpassed, leading to glucosuria, glucose in the urine. Over time, the persistent high blood glucose levels cause damage to the kidney's microvascular system, initiating diabetic nephropathy. Elevated blood glucose accelerates the production of advanced glycation end products, AGEs, which cause thickening and scarring of the glomerular basement membrane, impairing kidney function. Additionally, hyperglycemia promotes inflammation and fibrosis, contributing to glomerular filtration rate (GR) decline. Diabetic nephropathy is characterized by proteinuria, the presence of excess protein in the urine, edema, and eventually end-stage renal disease (ESRD). The progression of nephropathy can be slowed with tight blood glucose and blood pressure control, as well as the use of medications such as angiotensin-converting enzyme ACE inhibitors or angiotensin receptor blockers, ARBs, which can reduce proteinuria. How does a balanced diet influence blood sugar control in diabetes, and what dietary components should be emphasized for optimal management? Answer: a balanced diet plays a critical role in managing diabetes by helping to stabilize blood glucose levels and improve overall health. The primary dietary goal for individuals with diabetes is to maintain consistent blood sugar levels throughout the day. This can be achieved by consuming meals with a balanced mix of macronutrients, carbohydrates, proteins, and fats. Carbohydrate intake has the most significant impact on blood glucose levels, so managing the type and amount of carbohydrates is essential. Protein intake helps with blood sugar regulation by promoting satiety and slowing down the absorption of glucose from carbohydrates. Healthy fats, especially omega-3 fatty acids found in fish, flax seeds, and walnuts, contribute to cardiovascular health, which is vital given the increased cardiovascular risk in individuals with diabetes. Additionally, fiber-rich foods, such as vegetables, fruits, and whole grains, aid in blood sugar control and digestion. Portion control is also essential to prevent overeating, which can lead to hypoglycemia. The American Diabetes Association (ADA) recommends a personalized eating plan emphasizing whole foods, nutrient-dense meals, and limiting processed foods and added sugars. Explain the relationship between diabetes and cardiovascular disease and the strategies for managing cardiovascular risk in individuals with diabetes. Answer: diabetes, especially type 2, significantly increases the risk of cardiovascular disease (CVD). Chronic hypoglycemia promotes the development of atherosclerosis by damaging the endothelial lining of blood vessels, leading to plaque buildup. High blood glucose also increases the levels of advanced glycation end products (AGEs), which cause further damage to blood vessel walls. Additionally, diabetes is often accompanied by other risk factors for CVD, such as hypertension, dyslipidemia, high LDL cholesterol, and low HDL cholesterol, and obesity, all of which compound the cardiovascular risk. To manage cardiovascular risk in individuals with diabetes, several strategies are essential. Glycemic control, tight management of blood glucose through medications, insulin, oral agents, along with lifestyle modifications, reduces the long-term risk of cardiovascular complications. Blood pressure control, keeping blood pressure within a target range, usually 104 to 90 millimeters Hg, is crucial. Antihypertensive medications like ACE inhibitors or ARBs are often prescribed. Cholesterol management. Statins are commonly used to lower LDL cholesterol and reduce the risk of cardiovascular events in individuals with diabetes. Lifestyle changes. Regular physical activity, a healthy diet, low in saturated fats and high in fiber, weight management, and smoking cessation all play vital roles in reducing CVD risk. Aspirin therapy. In certain high-risk individuals, low-dose aspirin may be recommended for its antiplatelet effects. Regular screening for cardiovascular risk factors and early intervention can significantly reduce the incidence of heart disease in individuals with diabetes.